happy Thursday, February 3rd. Did anybody see if the groundhog saw its shadow or not?
I heard it saw it, or didn't see its shadow.
I heard the same, Sam.
Can someone remind me what that means? I never remember.
I think if it sees its shadow, it's some more weeks of winter. I don't remember how many.
It doesn't matter, Megan. But it made a great movie.
Precisely why I probably never remember, Kathy.
Julie
it's
in the
6
chat said
weeks.
no shadow.
Yeah, 6 weeks if there's no shadow, but who cares, right?
Yeah, Sam said 6 more weeks of winter, according to my team.
Hi, Christine. Good to hear you.
Yes, you did, Gwen. How are you, honey?
I'm good. I love
good.
hearing your voice.
No, really? Oh,
Yes, always.
well,
Christine is in like every study known to man too. We love Christine.
oh God, you're gonna make me cry. Gwen, you're like awesome. That's so nice of you. Thank you, honey.
We will get started in about 1 more minute, just letting everybody in. Thank you all for joining on this Thursday morning or early afternoon, depending where you are in the world. And also just to note that we are recording this. We realize not everybody can take the time, so we'll make sure that we post this on our I AM ALS YouTube page for anybody who misses it. And then as we go, we will be sharing just some slides to begin with, but you guys know that we are here and always want to be inclusive. So raise your hand, speak when you want to, or also put something in the chat, and we'll make sure that everybody is acknowledged and has their voice or question heard and answered. Okay, without further ado, Dr. Megan Miller. She is our Director of Research and Policy.
Hi, everyone. Thank you, Teresa. I am going to share some slides in a minute, but I thought just a quick kind of overview of why we're here today, who I am and who these lovely people on your screen are, just so you kind of understand. I always find it helpful to know the perspectives of the people that are talking to you and with you. So as Teresa said, I'm Megan Miller. I am the Director of Science and Policy at I AM ALS. I've been with the organization about 6 months now. My background is in neuroscience. I spent nearly 2 decades as a research scientist working in universities. As that relates to NIH, I spent a lot of time applying to NIH for grants, sometimes successfully, sometimes not successfully. But I do have a lot of experience from that end of things, understanding, NIH's role in academic research. From there, I spent some time also working for the US government, administering grants and building grant programs for the US Agency for International Development, not NIH, but some similar processes, which I think are helpful in understanding just kind of like how the government apparatus works. And then I found this amazing organization 6 months ago, and I'm happy to be here now, bringing those perspectives to the conversation. Also joining us in kind of facilitating and leading the conversation today, we have a number of community members who are on the call, but I'm going to highlight especially the 4 that you see on the screen here. First, Jean, who is, if you want to just wave, thanks. Hi, Jean. Jean is the lead of our familial ALS community team. She's going to bring her perspective on research priorities from the familial standpoint. And then we have 3 members of our clinical trials community team who are also involved in a separate but related effort called the ALS Problem Solvers. And you can see that Kathy and Gwen are donning their t-shirts. Sandy is in spirit. So Gwen Peterson, Kathy Collette, and Sandy Morris. And all 4 of these folks have been tremendous thought partners as we think about how to approach the RFI process. And they're not alone. There are also, maybe a dozen other community members who have weighed in here and there and who we've had conversations with. So just a quick introduction there, and then you'll get to hear directly from them in a little bit. So I guess, Emily, if you wouldn't mind sharing slides, and I'll get us started. Again, just a few slides, and then we plan to spend quite a lot of time just in open discussion and question and answer. I just thought it would be good to kind of like level set so everyone has the same background information before we get going. Okay. I think if you go to the slideshow one, Emily, up at the top right. Yeah. There we go. All right.
My Zoom chat window was hiding it. There we go.
Oh. All right. So yes, we are here for a community conversation about how we might have the opportunity that's in front of us to influence the future of ALS research in the US and certainly at the NIH. So next slide, please. Okay, so just a quick overview of what the NIH is. NIH stands for National Institutes of Health. I have copied their mission statement, their overarching mission statement here from their website, which is to seek fundamental knowledge about the nature and behavior of living systems and the application of that knowledge to enhance health, lengthen life, and reduce illness and disability. So they work across the biomedical sciences, touch at virtually every disease area, and even areas of biology that aren't directly related to disease states, with the goal of, in the end, affecting and improving the health of the public. They have an annual budget of just over $40 billion. That was 2021, which it's anticipated to go up in 2022. They are the largest public funder of biomedical research in the United States. In addition to being a research funder, they do support research projects that happen at the National Institutes of Health, which is headquartered in Bethesda, Maryland. They have really thousands of labs and experts doing their own research at NIH, which is funded out of that annual budget. But the vast majority of their research money goes to competitive research grants, which are given to research teams and institutions around the United States through a competitive process. They're peer reviewed, and really they tend to really like drive the direction of biomedical research in the US for that reason, because they are the biggest funder, and because, as I said, as a former academic, we all are vying for NIH resources to do our work. So from there, the National Institutes of Health, as I said, they touch all the disease areas and even some non-disease areas. They're divided into 28 separate, what are called institutes and centers, which have different focus areas. So on the next slide, we will highlight the one that we are here today to discuss, which is, oh, I think we went one too far, Emily. Yeah, there we go. The National Institute of Neurological Disease and Stroke. NINDS is how we refer to it. The mission of NINDS is to seek fundamental knowledge about the brain and the nervous system, and then to use that knowledge to reduce the burden of neurological disease for all people. This is one of several institutes that funds research in the neurosciences. It is the biggest funder of ALS research currently, but not the only one. There are other institutes like the National Institute of Aging, and National Institute of Translational Medicine that also have some ALS research programs, but I think NINDS is the largest. It is led by this gentleman in the bottom right corner, Dr. Walter Koroshetz. The total budget of NINDS is around $2.8 billion. It is also slated to go up in 2022. And as I said, it's one of several institutes that conducts and funds. So they do have some internal research going on, and then they also fund ALS research. Next slide, please. So that brings us to the opportunity we're here to discuss today. Earlier I guess last month now, in January, NINDS released what's called a request for information, or an RFI. This is a mechanism that government agencies often use to get input from the community more broadly before setting priorities for their organization. This request for information is, I think actually, Emily, can you go back one slide? I think there was one more. Ooh. There we go. So it is intending to, the request for information will inform the first ever strategic plan for ALS research, which is something that NINDS will be generating throughout the course of this year. And they want to hear from all of us in the ALS community about what the research priorities should be. What are the pain points in the community? What are the opportunities that we see for improvement? And I pulled here a quote from the RFI, which is also linked at the bottom there. And Emily, I think, is going to put some of these resources in the chat as well. It says that the goal of the strategic plan is to identify the highest priorities for research that will lead to the discovery of effective interventions for diagnosis, treatment, management, prevention, or cure. So it kind of runs the gamut. So it's not just like, they're not just asking like, how do we cure ALS? They're asking like, what are the challenges that you as a community are having, and how might we use research to alleviate some of them? Okay, so next slide, and we get into a little bit of the logistics. So the RFI, your response is due on February 11th. Again, the link is there. It's a really simple form. You just put in your name and information. It's just like an open text box. You can add, you can tell them, what your thoughts are. The responses will be shared with some working groups that they're assembling, for which there was a nomination process earlier this year. We already nominated some of our community members to serve as representatives from the community on those working groups. And then in late October, the working groups will present their findings and their sort of like draft priorities to the public. So those are publicly available and free to attend. And then there'll be an opportunity for additional input at that point. And then there would be revisions of those priorities, which would then be subject to a public comment period. NINDS has not given us a timeline for when this process is going to be absolutely finalized. If I were to guess, I would say early next year. But that is one of several questions that we're starting to collect so that we can, engage with them and better understand what this process will look like and where we might be able to influence along the way. Okay, next slide, please. Oh. Okay. So the prompts I'm not going to read all of these, but these are the bullet points that NINDS specifically calls out in the RFA for areas that they're interested in having community input. So you'll see there are 7 of them. The ones that are highlighted in yellow, I think, are the ones that this community has a unique, expertise in, and where I think we need to really show up the strongest to let them know what the areas are for them to prioritize moving forward. So for instance, the biggest challenges for people currently living with ALS and their caregivers. You know, the research scientists of the world are not going to be able to answer that question nearly as well as obviously this group can. So like, we really need to show up and tell them, you know, this is what we need. This is what we're experiencing. This is what we're feeling. And then things like interventions or technologies that might improve quality of life, inequities that inhibit or that limit the ability of the ALS community to participate in the research process. So we can come back to these later when we're having a discussion if you'd like. I don't want to go through them too much, but just to kind of give you a flavor of the type of information that I think this group is really well equipped to provide. So next slide, please. Okay, so just one quick overview of why we think this is so important. So NIH in 2021 spent about $110 million in on ALS research. It is expected to increase in 2022 to at least 115 million, and that does not include the money which will hopefully be appropriated for Act for ALS, which is kind of a separate conversation to have. This is not related to Act for ALS really at all, although they will both be implemented at NINDS. They're sort of, I think we should think of them for the time being as separate kind of pots of money and separate programs. About 70% of the NINDS budget goes to research grants, as I mentioned earlier, and that goes to funding thousands of research and training grants each year. And so as I was mentioning earlier, speaking as a former academic, I know that like in the halls of academic research institutes, people pay a lot of attention to what the NIH is doing and what they're prioritizing, because the way that grants are funded is the NIH will release a funding opportunity and say, these are the priorities that we've identified. We want to fund research projects that address these priorities. And people in academia see that and they say, oh, I have this like back burner project that is sort of related to this. Maybe we could submit this as an application and get funding so that we can like go into that new field. Or it might be, this is related to what I'm doing. Maybe I can pivot a little bit and have a chance at getting, you know, this big research award from NIH. So all that to say that the academic community really does in many ways kind of follow NIH's lead in setting priorities kind of organically because of the chase for research dollars and funding so that they can continue their research programs. And then beyond that, NIH is obviously a global thought leader in biomedical research. They are present at all of the major scientific conferences, and they even host their own sometimes. And I think that like they are a very powerful sort of force in the field. And this is our opportunity, which doesn't come around very often, to tell them specifically what our community is in need of. Okay, so I think this is maybe a good time to pause. What is the next slide, Emily? Yeah, okay, so we're gonna pause now and let's maybe stop sharing for a second, Emily, and we'll just turn to the chat and see if there are any initial questions. The second part of the conversation was I was going to turn it over to some of our community members to tell you about some of the priorities they've identified in this space, in case that is helpful or useful for you in thinking about like what sorts of things you might want to tell NIH about. And then yeah, so I'll pause there and we'll do chat first and then any other questions. Am I reading the chat, Teresa?
Sorry, I can. We were talking about Groundhog's Day, and that's when Julie said there was no shadow. Sam said 6 more weeks of winter, according to my team. And then Julie said that the groundhog did see his shadow. Garrett Smith said, hello, everyone. Hope everyone's having a great day. Kathleen said, hi, Garrett, you too. Sandy said, hello, everybody. Gwen said, I hope you're having a great day, Garrett. Glad you're here. Sandy said, I just forgot to change my photo to my t-shirt today. Darn it. This is her problem solver t-shirt. CJ said, anyone have experience with body science in Miami? Mary said, I saw the body science ads. I was wondering also. Ed said,
Teresa, really quick, I'd love to jump in. I have no disclaimer. I have no affiliations with body science. I'm lucky to know folks in the ALS community who have been to body science and can shed more light. So for anyone who would like information in chat, DM me, private message me with your email, and I will connect you with who I know. But let's take that one offline, everyone. Thank you.
okay, Ed had asked, will we discuss stem cell therapy? Kathleen dropped the link. Here's the link to learn more about the NINDS, ALS, RFI, and to submit. CJ said, I have a meeting with Amy February 16th at Body Science. Gwen mentioned, anyone interested in body science, I can make an introduction to the ALS community members who can give testimonials. We can take that offline. And again, if you can send her a DM with your email, she'll follow up. Julie mentioned, I've also been looking into body science and would appreciate any feedback. George said, USA FDA currently has an ALS clinical trial phase 3. It is also happening in Canada. How can this be advanced? Richard said, there has been no longevity improvement in the past 80 plus years. When Lou Gehrig was diagnosed with ALS in 1939, the average survival rate was between 2 to 5 years. 80 plus years later, their survival rate is still just between 2 to 5 years. In those 80 plus years, there have been only 2 FDA approved treatments that have only a very minimal benefit. Mary said, are the prominent physicians and researchers contributing to RFI? I am a doctor, but my primary role is mom to newly diagnosed ALS son. I have learned there are issues with mitochondria, protein in the cytoplasm, and not nucleus, microglia. I think I'm saying that right, microglia. But I am not able to state what needs to be prioritized in the scientific process. Will making progress in ALS research be harmed by getting a lot of responses from people like myself who do not understand the complex scientific ALS metabolic pathways? Are the leaders in ALS, scientists and doctors, contributing in an organized and strong manner to the RFI? Mary, we will get back to that and discuss that. Richard is saying, 1, find the biomarkers, government support, and tax incentives with oversight for ALS research grants and finding biomarkers, which will result in faster ALS diagnosis and eliminate the need to first rule out other diseases. 2, genetic testing. Genetic testing is required for all patients with ALS. The more data collected, then the more likely patterns will be found. Genetic testing also required for all patients with ALS and their twins that do not have ALS. Look for differences that may identify a potential ALS mutation. Social Security disability payments for all ALS diagnosis should be contingent upon the recipient participating in genetic testing and free genetic testing for all patients with ALS and their twins. Richard goes on to say the ALS National Registry and national database participation is required for all patients with ALS and their twins. Social Security disability insurance payments for all ALS diagnosis should be contingent upon the receipt of enrolling within the ALS registry. Clinical trials is number 4. Wider eligibility criteria have subgroups for people that don't meet the exact entrance criteria. Open label extension for all phase 3 and late phase 2 trials. When a trial participant reaches the specific point of decline, typically a rapid decliner, the participant is moved off the study drug and switched to the actual drug through open label extension. People not eligible for clinical trials and that are allowed to participate in an expanded access program, their data should be included in along with the eligible clinical trial participants for a wide pool of people that can be studied. Measuring physical ability and decline is the fifth one. Find a better way than the current ALS FRS way to measure physical decline over time and using biomarkers. Oh my gosh, Richard, you are putting your full thesis in here, huh? Jim is sharing, can you provide status of work done by Avi Nath's work on HERV-K? Was this work initiated by NIH and what are the next steps? Perhaps I can pause here.
Let's back up to a couple of the earlier questions. Teresa, I saw something about stem cells. If we can back up to kind of that area, start there.
Yeah, so the first one in the chat was from Ed. Will we discuss stem cell therapy?
So Ed, I don't think that we had specific points about stem cell therapy on today's call, but that's certainly something that, you know, if you have thoughts and feelings and call that a priority in ALS research, then that is exactly the type of thing that I think the NINDS could hear from the community. So we would encourage that, and certainly if you'd like to chat more about it offline, I'd be happy, and certainly and probably others on the call.
And I was in the neuro trial, and I flew to South Korea for core STEM, and I'm in the neuro EAP, so I'm your person. But for today's discussion, basically what we're trying to line out for the RFI comments, for the NINDS, is to ask them to get on board with our disease. So today is not for the specifics of HERV-K or stem cell. And sadly, we're all painfully aware that we're still where Lou Gehrig is. And that is why today is so critically important to understand the comments that you want to get to the scientific leaders. Just tell them that the time is now to get themselves together and do for us what they have done for others, other disease states. And we're just about to show you how we think that a consistent, unified messages will really put us in the best spot. So that 80 years from today, people aren't saying 160 years ago, Lou Gehrig had the same chances as we did. We have every ability to make this better. So I'd love for everybody to be able to lead this webinar in a half hour with the right idea of what the scientific leaders need to hear. But if you want body science, that's one. If you want stem cells, I'm all yours. Is it okay if we get through the rest of the slide deck? Would that be a good half a plan?
That's a great idea. And on the same note, Sandy and everyone, if we can line out the differences of FDA and NIH and what the two sort of support, that would be great. You know, let's get sort of stick to like basics if possible to get a foundation. Thank you.
Yeah, definitely. Let me just give like a 2-minute response to that, Gwen. And I think we have more on it coming in the presentation, but just because it's timely, because of some of the questions, I think that's a good call. So 2-minute overview, and then I'm going to pass to Jean to talk about some of the familial priorities that have been identified. So the NIH is generally interested in what we call preclinical research. So things that happen early in, like they might be investigative in nature, like I said, like they do like basic biology, through early stage clinical trials. So their primary mandate is for research only. They want to learn as much as they can. The FDA then picks things up when there is a drug that, for instance, it has been through development, is through phase 3 trials usually, where a company who is developing a drug would submit, or drug or a therapeutic, a device, a medical device, would submit an application to the FDA, and the FDA is responsible for reviewing, approving, regulating, and ensuring the safety of something before it enters the market. So they are sort of separate. NIH has nothing to do with, for instance, Neuron or any of the drugs that are in the pipeline with a pending approval currently. They come in, they invest heavily in the research that leads to eventual cures or treatments for diseases. So I think that is an important distinction to make when crafting a response to the RFI, because if we want our voices to be heard, we have to understand like their perspective and what it is they're interested in hearing, so that we don't go to them with a whole bunch of like, approved drugs now, because they have no authority over the approval process. So I think that is a really important thing to call out. Okay, so Emily, if we could go ahead and pull up the slides again to Gwen's slide on the familial priorities.
So I'll just start talking. So my name is Jean Swidler. I am a co-chair of the familial ALS team at I AM ALS. Just very briefly, familial ALS is when there's specific mutations or suspected mutations that go through families and mean that the disease manifests in multiple generations. In my family, it was my great-grandfather was the first one diagnosed with ALS and died from it in 1970. My grandmother died of ALS in 1990, and my mom died of ALS in 2019. I confirmed that I carry the mutation, and the average age of onset in our mutation, which is the most common one, C9orf72, goes between the 20s and the 80s, with the most common onset like 58. So anyway, that's some background on myself, and the perspective of the familial ALS team is we're really the first group of people looking at the interests of the many thousands of folks who are at risk for developing ALS. Heightened risk. So here's some of our priorities. So the first one, we have a very lawyerly definition of it that is in our email to people. And I think we have one of our teammates on the call. She should feel free to jump in, Sam, who helped describe it. But this more compressed version is pre-manifest care and disease prevention. So I wanted to highlight that in the Alzheimer's community, the NIH does run prevention clinical trials in people at risk of early onset Alzheimer's. So it is something that the NIH has experience in. Separately, I do think that the NIH needs to get their head reset on this a bit. I spoke with Brian Traynor, who is a top NIH expert and a gentleman who discovered the C9orf72 gene. So, he's a brilliant person, but he did not see the need for pre-manifest disease prevention, really. Like, he was like, oh, don't worry about it, basically, and I think that's a very naive way of thinking about it. So I think they really need to get their head on straight about this. And that's, of course, a unique need for the people who are impacted by this. And there are tens of thousands of folks in the US alone who are at risk of developing these diseases. But It's also, I think, very important for the whole entire ALS community because we are not trying to stop the disease at its earliest points yet. Current clinical trials only recruit folks who have a diagnosis of ALS, even though over the last 5-6 years, they've identified the start of the disease in genetic carriers up to 15 years before classical symptom onset that would warrant a diagnosis. So if there are efficacious drugs and there is this long prodromal period, it's called, where the disease is active in the body and not yet showing up in very obvious clinical symptoms, why would we not want to see if drugs respond well at that early stage of the disease? And that could perhaps be more instructive about the efficacy of a drug than testing it later in the disease course. And I think that might prove beneficial for drug approvals for the whole community. Once you can show that it does something when the disease is early, it makes sense that it would also do something later on in the disease, although perhaps not quite as dramatically. So that's my pitch for that one. We want an increase in research for those at risk of familial ALS. Right now, the NIH pays for one study in Miami of people at risk of familial ALS, and this really provides the only way of looking at the disease before symptoms are present. And that's really where this disease needs to go, is early diagnosis and treatment. We should not be waiting for intervention for people to have severe disabilities. It doesn't make sense. So we want there to be centers who are doing this research all over the place, not just in Miami. So that's another. The third is better connectivity in C9orf72 research between ALS and FTD and other dementias. So C9orf72, by far the most common disease-causing mutation in ALS, is also by far the most common disease-causing mutation in FTD. And the NIH does a lot of work on FTD, and let's make sure that the scientists in these two communities are connecting and know what's going on with each other. Also, if we're looking at biomarkers, we should look at non-invasive biomarkers as a preference. Obviously, there's a lot going on in the central nervous system in ALS, and doing spinal taps is important. But all things considered, if there's a biomarker candidate in the blood or in speech or in an eye scan or something, I think that should be given priority over a biomarker candidate that's only accessible via spinal taps, especially if we're thinking about lifelong monitoring of the disease. It becomes all the more important to have non-invasive biomarker candidates. Finally, we want whole genome sequencing in all research projects with patient samples, obviously only one per subject or patient. For instance, in my family, they just test for C9orf72. And, now we are known as, my mom's samples, she donated her brain, of course. It's a C9orf72 brain, but did they do a whole genome sequencing on her? Because there's probably other gene mutations involved in these things. So that's our 5 things that we think would be good for the NIH to hear. Sam, I don't know if you have anything to add that I messed up on.
No, you did great. I appreciate the overview.
So I know the ALS problem solvers have a great presentation, so I'll leave it to them unless, Megan, you have anything you think I should clarify.
Oh, that was awesome, Jean. Just pointing out here on the slide that there is a link to learn more about the familial ALS team for anyone who might be interested in joining their work.
Thank you, Jean. And Megan, thank you very much for doing this meeting. This is a huge opportunity, I think. I'm Kathy in Indianapolis, Indiana. I'm one of the ALS problem solvers. Gwen and Sandy are here with me, and I'm going to go really fast, so stop me if I need to slow it down. The ALS problem solvers we're a group of people with ALS and caregivers who kind of found each other a little over a year ago. And we stumbled onto this problem of not using proven NIH expertise. NIH has been great supplying grants, doing a lot of early science for ALS. We've always asked for more money for NIH. But we've been missing the boat on using the expertise, the things that they know how to do and do well that they've done for other diseases. So problem solvers got together and we put together a paper trying to make some points about here NIH, here are things that NINDS could do for ALS, and you know darn well how to do them for other diseases. And we presented that information to NINDS on October 20th of last year. And things were well received. They listened to us and they said we presented them with a good blend of science and lived human experience. So when they decided to do the strategic plan, we were ecstatic. And we don't think it's just a strategic plan that's going to be put on a shelf someplace. We think they will actually use it in setting priorities for years forward. So that's why we think this is so important. The problem solvers presented to NIH 5 things that we think can change everything that NIH can supply to us. And we depicted these as 5 cogs in a machine. These work together. It's not that you just pick one or pick 2. These 5 things need to work together. And if they do, we will change a lot. And these are 5 things that NIH knows how to do very well. Number 1 is an expansive natural history study. And we're talking, I say honking big, a big natural history study. It has to have a lot of patients in it. Gwen eloquently says it needs to be a come one, come all natural history study. It has to be broad. It has to be deep. It has to go into Jean's point. We have to dig in and find the right kinds of data on these people.
And Kathy, no one's excluded, or no one should be excluded, right? This is everyone, and ALS progresses differently in every one of us. And that's why we want this to start, at diagnosis, start collecting data from us as early as at diagnosis.
And this has never happened before.
Right.
We have spits and starts, and we did a big rubric on it, and it's not going to help us. So this is why we're asking for your help. Today, ALS is fragmented at levels where we deserve organization and orchestrated effort and expertise. And starting with the NHS would help us so much.
And
Kathy. Oh, sorry, go.
No, thank you. We're all friends. We're gonna talk over each other. One last thing. So many of us don't qualify for clinical trials in general. Certainly most of us don't qualify for ones with an experimental therapy. How nice would it be as people living with ALS to contribute to the science, right? That's all we're asking for. We want to contribute and move the science forward. Thanks, Kathy.
Thank you, Gwen, and thanks, Sandy. And NIH itself has said that natural history studies are kind of the launching pad for all kinds of research. So they recognize the importance of natural history studies. The ALS landscape is littered with small ones that have kind of come and gone. We need something that's done right, and they know how to do them right. So we are asking them for a natural history study, a big natural history study that is broad and deep. We also want a comprehensive clinical trials network. For as great as NEALS is, and for as great as the reach that NEALS has, it's a limited number of sites, and we know that there aren't enough seats on the clinical trials bus. Some people, I think on this call, were involved in going in and counting the number of seats in clinical trials available to people with ALS. The number's well under 2,000. That leaves perhaps 25 to 28,000 people sitting at the curb who can't get into a clinical trial. Jim asked about Dr. Nath's work at NIH. He is an intramural scientist. He works for NIH. And he is doing a study at Bethesda on HERV-K in ALS. That is the only clinical trial going on in their huge research center at Bethesda for ALS. That's not acceptable. We need more trials done at NIH, and we need them to help establish a broader network. Tim Lowry, I think, is on the call. He's another one of the problem solvers. He lives in Buffalo, New York. That is not a small town. That is a major city, and he couldn't find a clinical trial. So we need NIH to help with a broader clinical trials network to get more people on the bus. Number 3 is a parallel track, and we use parallel track terminology with NIH because it's something that's familiar to them from HIV, AIDS kinds of days when they established a parallel track of expanded access to benefit people who are not eligible for trials and to get some informative data from them. Kind of sounds familiar today to expanded access. And we think that NINDS can help make it more efficient and make it more informative by giving some process and some infrastructure to that. NINDS leadership, I think that
Kathy,
yes,
can
Gwen,
I
please.
call? So sorry. One quick thing. NIH and NINDS like the word parallel track. Certainly it's very similar to EAP, but it is a term that's recognized and that's, worked for HIV. So if you're going to call out something in your RFI, parallel track is the way to describe it. That's it.
Thank you. Important point, Gwen. Thank you so much. We're asking for NINDS leadership, and that's not just a pat on the back leadership. We feel that the ALS portfolio needs active management. We feel like there's science out there that is kind of completed in granted research that has died on the vine that's worth picking up and moving with. And there's probably other science out there that the book needs to be closed on. And we just feel like NINDS needs to step up with some leadership. And to Jean's earlier point, there are other institutes doing things related to ALS, and we need for NINDS to step up and make sure that things are in concert so that we're not having these little silos that are expensive and wasteful. And then finally, our relationship and the problem solvers. We want to be at tables with you. We do not want something akin to a children's table at a big banquet, which is the way people with ALS and caregivers have been handled in the past by many government organizations. We want to be there on these teams for strategic plan. We want to be there on teams when you're developing a natural history study, working on a clinical trials network, et cetera. So those were our 5 asks, and we are putting into the RFI individually and as a group comments that really track with these. So Megan, I thank you very much for this opportunity, and I'm glad to help with any questions. I'd like to send people to alsproblemsolvers.org. On the What's New page, there's a little video that you can watch. It takes 5 minutes and it explains things much better than I did. So thank you.
I was able to drop that link in the chat, Kathy, thank you. And I'm going to read out what Sandy had written in the chat as well as they relate to this slide. Sandy said, we all want to contribute to the science, and these are the ways that will help us within NHS and clinical trials if eligible, and if not eligible, parallel tracking through EAP. The scientific leaders are used to the word parallel track. The ALS community more commonly uses the term expanded access. So just wanted to, before we moved on, to make sure that Sandy's comments were in there as well.
Thanks so much, y'all. That was super informative. I recognize that we're about out of time, and so I want to leave a little bit of time for discussion. If we could just skip, though, Emily, to the very last slide, and we can make these slides available to folks also afterwards. Sorry, I guess it's the second to last slide with the 4 tips. Yeah, that one. So I guess these, I'd like to just end with this. 4 tips to be sure your voice is heard in the NINDS RFI process. So 1, know what NINDS does and doesn't do. So this is what we were talking about earlier between like what NIH's lane is and what FDA's lane is. It doesn't mean that we can't push boundaries, but it does mean just like recognizing that they don't have regulatory authority, for instance. The second is focus on what you know. So you heard a lot here from Gwen and Kathy and Sandy and Jean, who have spent a lot of time talking about like, or thinking about the ALS landscape, the research landscape. I mean, Kathy has been in this work for decades now, has such an amazing historical perspective and comes with all of that knowledge at this. But that if you don't have that, that doesn't mean you shouldn't also still provide input. So if we go back to some of those prompts, we're like, what are the challenges of living with ALS? Tell NIH how research might be able to help that. You don't have to answer all of the questions. You don't have to go into depth about any of the things that Kathy or Jean went through. Just focus on like the areas that you know about and provide your expert recommendations or experience in a way that is easy for them to understand. I would say be sure to answer the questions that are asked. So they're telling us in the RFI, we want to know specifically information about these things. That doesn't mean you can't stray from that a little bit, but I would say call out the questions, based on your question number 4, here's my response. These are the things that I, in my experience, have identified as a pain point that I think that NIH might help find a solution to. And then lastly, share gratitude with the NIH for this opportunity. We want to be, and this is kind of gets to Kathy's final point on her slide, we want to be thought partners in this, and that starts with, and they should be coming to us, absolutely, but we should also be like thanking them for doing the right thing and doing that, and really positioning ourselves as thought partners moving forward. So I'll stop there with the slides and then welcome, Gwen.
Sandy had dropped a 5th tip in chat. Kathleen, wondering if you can read her comment.
Absolutely. Sandy said, even if you don't want to submit a lot of words for the RFI comments, at the very least, tell them that we deserve more, as they have done for other disease states. We deserve the expertise and leadership to find the therapies that will work for this heterogeneous disease.
Okay, so I know that was a lot, and we are only 4 minutes away from the end of the hour, but if there are burning questions, feel free to raise now. You can always email me. I'll put my email in here. Also, I AM ALS is compiling our own response to this as an organization, which we will make publicly available sometime next week. So that will be, for transparency and for reference.
If it's okay if I just have one more thing.
Yeah.
One thing that we cannot do, guys, is be angry at this disease, complain that nothing gets done, and not get our comments and our passion to the powers to be that can help us. So please, for the love of God, make sure that your comments get to these leaders who are willing to put together a strategic plan to attack this brutal disease. At last, the fragmented approach that we have been using for 150 plus years has been useless. It has always been up to us to push the science, to push the processes, to push the possibilities. So please don't sit back and be angry at this disease. Push your rage or your sadness into something productive. that might help save your own life or somebody that you love or somebody that is going to be diagnosed this morning. Please help us with this. It is entirely possible. We appreciate your hour more than you'll ever know. Take what you've heard here, put it in your own words, with your own ideas, and tell those leaders that the time to act is now. Thank you.
How soon will this recording be available? And will we be able to share it? And where do we find it?
Yeah, I can take that one, Katrina. We're going to post it to YouTube, our YouTube channel this afternoon, and we'll share it out to everyone who signed up to join, and we'll also share it out on social. So this afternoon, you all should have access to it.
And Mary asks a question in chat. Is the ALS letter posted so we can copy I AM ALS's points or the problem solvers points in our RFI? Great question.
So we have not finished ours yet as an organization yet. The problem solvers have a full report on their website, which is definitely worth reading. We can make the slides from this presentation available. I'm sure Jean would be happy to share the familial team's more elaborated points. What's on the slide is kind of abbreviated. So yeah, absolutely. We'll make all of that available before the deadline. Some of it is available now. Other pieces will be available next week.
And to Mary's point, on the problem solvers website, it's on the What's New page, but there's a one pager that has every one of the NINDS topics that they want addressed, and it shows how one or more of the COGs can address that. And I think that might be helpful for people just trying to put some comments together. Thank you.
And if there's any further questions after we hang up, where can people direct those to? At I AM community at I AM ALS, or
that works, or me directly is fine too. I put my email in there. Yeah, feel free to reach out.
Right.
We also, as I mentioned at the top, have some outstanding questions of our own for NIH, which we are hoping to get answered. And so like, if there are questions that I can relay to them and try to get responses for, I'm happy to do that. Hopefully we'll get something, some kind of response from them before the deadline. So.
And thank you, Lynn. We see your comment. Thank you.
Yes, thank you all for joining. Thanks for being part of this revolution and making change with us.